A little bit early. I've added slides with all the extra in-training questions, and I feel it's all important. We're going to start where we left off yesterday with total knees, where we were balancing in the coronal plane, and now we're going to balance in the sagittal plane. This is important, and this balancing in the sagittal plane is also known as balancing the gaps, extension and flexion gaps. It's important to balance the gaps for range of motion, stability, prevention of flexion contracture. This is what's going to get you a range of motion by maintaining that joint line and having adequate balance. Now, as a general rule, when it comes to test questions, there's always going to be a test question on balancing the gaps. And when it's in the middle of the test, you got to think, what am I going to do? What am I going to do? This is how you remember it, and this is how I remembered it for the boards, and it got me through it. If it's a symmetrical problem, you tinker with a tibia. If it's an asymmetrical problem, you tinker with a femur. Just remember that. That's the rule. Symmetrical problem, tinker with the tibia. Asymmetrical problem, tinker with the femur, and I'll show you the examples. If you look at the flexion gap, it's controlled by the AP cut of the femur, so the posterior condyles. If you cut them more, you're going to increase your gap. You look at the tibial cut. If you cut it, you're going to increase that flexion gap. And also, if you remove the PCL, that flexion gaps will pop open. So those are the three variables that control your flexion gap. In extension, I'm sorry the picture didn't show up. It's the same thing. The distal femoral cut controls the flexion gap. The tibial cut also controls the extension gap, and also the posterior capsule. So those are the three structures. So if you go through balancing of the gaps, here's the scenarios. I'm going to go through every single one of them. You're tight in extension and you're tight in flexion. Remember what it is. It's a symmetrical problem. Then you tinker with the tibia. So in this particular example, you're tight in both directions. What you need to do is cut more tibia, and that's how I figure out the answer. So if you just remember the initial rule, symmetrical problem, then you tinker with the tibia. Here you're loose in extension and loose in flexion. It's the opposite of what we just had. But again, I just want to emphasize the point. It is a symmetrical problem. Then you tinker with the tibia. So in this particular case, you've cut too much tibia down towards the fibular head. And what you need to do is put a thicker tibial insert. Or if you're already up at 22 millimeters or 23 millimeters on your tibial insert, what you're going to need to do, is if you're really screwed up, which I've done from time to time, is you put some metallic augmentations and build it up. And then you add your tibial insert. But again, the emphasis here is a symmetrical problem. You tinker with the tibia. So here you go, another gap problem. Your extension is okay, and your flexion is loose. This is an asymmetrical problem. And now what you're going to do is you're going to tinker with the femur. So extension's okay, so what I got to do is deal with the bottom part of the femur, the posterior condyles. So what you can do is the flexion's loose, so I can increase that flexion gap. I can add to the femur, and that's what you do is you increase the size of the femoral component anterior to posterior. You go to the next size up, either a B to a C or a 67 to a 72, and you add, for your deficiencies, you can put posterior augmentations on the femur, or you can put cement and screws. And that was on an in-training question just last year. They always ask it in some form or the other. So if you look here in this gap problem, AP extension's okay, AP gap is loose in flexion. What you need to do is build it up. So you go up to the next size femoral component and you fill in it with cement or metallic augmentation. Okay, balancing the gaps, extension is tight, flexion is okay. So what's happened here, you have, again, an asymmetrical problem. Your PCL is balanced in flexion, or you have a posterior stabilized knee, your ligaments come down and bend okay, but in extension you have a flexion contracture. So if you have an asymmetrical problem, again, you deal with the femur. Here you didn't cut enough distal femur, you just cut more femur off. Okay? Here's the example. So in flexion, your AP gap is okay. You bend just fine, but when you bring in an extension, your posterior capsule is tight. So what you do is you cut a little bit more distal femur off, and you're okay. One problem with this one, a nice subtle way to get through this if you wanted to, is you can say, flexion gap's okay, extension gap is a little tight. What you could do here is you could release the posterior capsule, but I've never seen that test question answered. The test questions I've seen year after year is cut more distal femur. Okay, balancing the gaps, extension is okay, flexion is tight. This is another good test question because there's a couple options involved. So you've cut your distal femur okay, your tibia is cut okay, you bend it, it's too tight. Again, it's an asymmetrical problem. You can ask this. This was an in-training question last year, the year before that, and the year before that. So what you do here is your flexion is tight. It's an asymmetrical problem. You deal with the femur. So either you go to a smaller femoral component, so you go downsize your femoral component and cut those posterior condyles off, or if your PCL is tight, because your PCL is tight in flexion, not in extension, but it's tight in flexion, you can recess the PCL and release it a little bit, or you can check your posterior slope. You have to check your posterior slope, because if you have an anterior slope, you won't bend. So those are the three things. So it's an asymmetrical problem. Deal with the femur. Here's the example. So your AP cap is too full. It won't bend all the way, so you cut more posterior femur. That's the number one answer, and then it loosens up the flexion gap. Now, if you have a posterior cruciate retaining knee, what can happen is sometimes the PCL is scarred and tight, and what will happen is if you're balancing this, what you'll see is that the gap here, when you bend the knee, this trial component will lift off like this, and that tells you that your PCL is too tight. It's pulling that insert and nut cracking it open. The PCL is tight, and what you're going to do is recess that PCL off the femur, or you can recess it off the tibia, and that's called the crack-out technique. Last thing, remember posterior slope. This is on the in-training last year. It's a great test question. If you have an anterior slope on your tibial component cut, then you're not going to bend your knee. So the first thing you always do is check your posterior slope. You got to make sure that your posterior slope's between anywhere between 6 to 9 degrees. Some say 6 to 10 degrees. Okay. There is a Polo test for cruciate retaining, cruciate sparing knees, and this is espoused by Dick Scott. It just gives you a test for stability for your flexion gap with a cruciate retaining knee. If you have this lift off that we're talking about right here, that means that your PCL is too tight, and what you've got to do is recess your PCL. If it's too loose, then you're able to pull that out back and forth, and that tibia shucks, and that's loose. And that's the Polo test, pull out, lift off. Another gap problem, flexion is okay, extension is loose. This is another way you can work with a couple options. Just remember, though, the rule, it's an asymmetrical problem, so you're going to deal with the femur. The most logical answer here would be your extension gap is too loose, so you add more distal femur with some distal femoral augmentation. The other way to think about this is, well, perhaps my extension gap is okay, and so what you do is you fill up the tibial side, and you have an extension. It comes into full extension now without recurvatum, and then you have a tight flexion gap. And so then you go back to the scenario, extension is okay, flexion is tight. So you can put a tibial insert that's thicker and address a tight flexion gap, and that's usually the problem. So there's two ways to answer that one. But remember, asymmetrical problem, deal with the femur, and then you can work through the problem. So here's the example. Again, the extension is loose, and you come into hyperextension. What you do is you add distal femur to straighten it out. Going on to prosthetic designs, they'll always ask a couple questions here on this, always. The designs are unconstrained, constrained, and then what I call a hinge, which is basically really constrained. The choices are cruciate retention, cruciate substituting, constrained high post, and constrained hinged prostheses. The advantage of a cruciate retaining implant has always been espoused to have femoral rollback, which gives you improved knee flexion compared to the total coronal knee. Remember, the initial total coronal knees had no ACL, no PCL. They bent real nice to about 95 degrees on average, but they didn't have that real good flexion. And one way that they thought about increasing the flexion was to preserve the femoral rollback. Femoral rollback, by definition, is a posterior shift in the tibial contact point as the knee flexes. It's controlled by the four-bar construct, ACL, PCL, and the two ligaments, two collateral ligaments. It allows the femur to clear the tibia. It is thought that with a cruciate, if you save the PCL, you will get that rollback. The disadvantage of that, if you're going to have rollback, is you have to flatten out the polyethylene insert, so that gives you high contact stresses. It does allow for some sliding, which is bad for the polyethylene, and we'll talk about that in catastrophic wear. And it gives you higher fail rates in the earlier designs, and we've worked around that. And this is a typical example of a failed cruciate retaining implant with a flat-on-flat design. They had this catastrophic wear, and I have a whole lecture about this. The posterior stabilized knee, which is cruciate resubstituting implants, recreates rollback mechanically with a cam and a spine. It improves the knee flexion. It tends to have congruent articulation, so there's less stress on the polyethylene, and it's easier for me to balance. If I cut out that PCL, all I have to do is rely on the extension and flexion gaps. I don't have to worry about the polo test, and all I have to do is deal with the femur and the tibial cuts and then adjust it. So for me, it's easier balancing, and what I find it's a more pleasant knee to work with. That's just my bias. PS implants, here it is. The cam engages the post during flexion, and it recreates rollback mechanically. It tends to be more predictable. The disadvantage here is you can't leave the flexion gap loose. The femur can jump the cam. Yeah, I'll show you. I have an x-ray example on it next. One of the other disadvantages is that you can develop a patellofemoral clunk syndrome, and I'll talk about it in another lecture. That's where you get scar tissue in that box. You got to remember about small knees. You have a real small knee like this one, you have a wide box design, you can remove a lot of bone in the middle there. So that's one disadvantage of a posterior stabilized knee, is that you take a lot of bone and don't have a lot left. This is the example of the loose flexion gap. Here's the posterior stabilized knee. You have that loose flexion gap like I show you there. You can jump that post, or jump that cam right in front of that post, right in this area right here. And this is the classic x-ray example for the boards. Posterior stabilized knee. You can see that the knee is subluxed, and it's on top of that polyethylene, and it's not in the right position. It just ain't right. And that is a cam jump. And I want you to memorize that. The treatment is acute closed reduction under anesthesia. You give them succinylcholine, paralyze them. You bend them in flexion, distract it open, and pull it back and reduce it. If you have a recurrent cam jump, then you've got to require a revision to adjust that loose flexion gap. Okay, memorize that picture. Now, special indications, people like to ask questions about that. Cruciate retaining knees are more indicated towards the hyperflexion cases where, for cultural reasons, your knee needs to bend to like 140 or 50 degrees. A posterior stabilized knee with the cam, if you bend towards 135 degrees, you're going to jump the cam. So if somebody requires hyperflexion, you need a cruciate retaining knee. A cruciate retaining knee is not as good for large deformities because of the problems of balancing. Laskin has shown that if you have varus greater than 10 degrees or a big valgus greater than 15 degrees, it's better to cut the PCL and you get better balancing and better reproducible results. So for big deformities, you want a posterior stabilized knee. For hyperflexion, you want a cruciate retaining knee. And also, patients with patellectomy, you want a posterior stabilized knee because the patella tendon and patella together keep that knee relatively stable. Whereas if you take out that patella itself, you lose that force, so there's a little bit more subluxation. That cam and post won't let you do that. So patients with patellectomies get posterior stabilized knees. I guarantee you that will be on the boards. If patients with inflammatory arthritis have erosive disease, so the PCL over time can rupture. So patients with those type of process should get a posterior stabilized knee. Those who have had prior trauma or PCL rupture obviously have to have a posterior stabilized knee. Okay. Now, going on to constraint. Why do you want to use constraint? Basically, the soft tissues about the knee won't support the prosthesis, so you have loss of key vital support structures. Therefore, the prosthesis must then accommodate for that loss of support. So the key support structures where you would think about using a constraint would be problems with the medial collateral ligament being damaged and stretched out. The posterior soft tissue complex is stretched out where you have hyperextension deformities and you can't balance it very well. Or that extension mechanism, either with a patellectomy or it's completely deficient, you lose some of the constraining force to the knee. So the reasons for constraining the total knee, first of all, inability to balance the flexion and extension gaps. So we balance the gaps, you can't get them balanced. So what you've got to do is you've got to add a high post in that system to help give you that support. Usually those are when you see hyperextension instability from post-polio or flexion gap instability. All the collateral ligaments are stretched out, and when you bend it, the gap's wide open. That's where you can use that high post to help you. Here's an example of a cruciate retaining revision knee at 5 years post-op. You got that PCL laxity, increased flexion gap. This is a good indication for a constrained knee. The other reasons for constraint, global instability, either from trauma or from infection. All the ligaments are just damaged and stretched out. Another relative indication is anticipated ligament stretch out. For example, reimplantation for infection. You have all this scar tissue, and then everything over time loosens up, and you become unstable. So the bottom line, what you need to know is what deficiency do you need to support, whether it's flexion or global or extension or mid-flexion. If it's global instability, we tend to go more towards the hinges. And can you make up the deficiency without a hinge? The rule for the boards is you don't want to use a hinge. Absolutely avoid the hinge if you need to. They work well in special circumstances, but that it's a highly constrained device, and they will break over time. What you want to do is use a high post as much as you can. In fact, you don't want to use any constraint in the knee system if you don't have to, but if you need to, you should. Pretty prophetic there, huh? So the choices for constraining the total knee, you have a high central post, which is not linked. Then you have a linked hinge with a rotating platform, which is the next option. The older ones were a linked hinge, no rotation. Those are the sagittal plane hinges. Those had a high failure rate, and those are not used anymore. So if you see linked hinge without any rotating platform, avoid that answer. So the definition for constraint non-linked prosthesis is an implant that has a high central post that substitutes for MCL and lateral collateral ligament function. That's the big post in the middle. Remember that a posterior stabilized knee, even though it has a post, is not constrained. You, in the sagittal or in the coronal plane, you do varus valgus stressing, you can tilt it and move it anywhere. That prosthesis on the right, which is an old TC3, it has a high post, and you do any varus valgus stressing, that will not rock off at all. And that's what I mean by a constrained high post. It gives you that medial, lateral, coronal plane support for deficient collateral ligaments. So when do you use a constrained knee, non-linked high post? It's when your MCL is attenuated and stretched out. Some use it for complete MCL deficiency, but that puts a lot of stress on that post, so that's a debatable question. But I would tend to use a high post for MCL deficiency. Anytime the lateral collateral ligament is stretched out or deficient, it's a good indication for the high post. And again, flexion gap laxity. If your extension's okay, you drop down to flexion and your gap open, that high post will keep your prosthesis stable. And that's a good test question, flexion gap laxity, high post. A hinge rotating platform. Again, the femur and tibia are linked with a connecting bar and bearings. The rotating platform allows the tibial component to rotate, so that takes some of that rotational stress off of the implant bone interface. It reduces the torque stresses, so you reduce the loosening. These are two examples. Again, you have connecting pins literally connecting the femur to the tibia, and then you have a yoke that goes into the tibial bearing. So those are highly constrained devices. The indications are for salvage reconstructions like after tumor, or here global instability. You've dislocated your knee, all the ligaments are torn and damaged. Or the other one is a great test question, hyperextension instability. That is a good test question. I'll show you an example. So again, if you have a tumor and you've resected all your ligaments, you've got to use a hinge. Charcot joints, that's relative. Some people will use the high post, and some people will use a hinge, so they won't test you on that. And again, relative indication, complete loss of the medial collateral ligament. Some people will use a high post, and some people will use a hinge. So I don't think they're going to ask that. They're going to ask you clear-cut answers. Example like this one, post-polio patient, standard total knee, post-op hyperextension. And I swear there's no high post non-linked implant that's going to take care of your hyperextension instability with post-polio. Nothing's going to happen here except for a hinge, okay? So the solution there for hyperextension instability post-polio is a hinge. And this is the example there, all right? Here's a case of a dislocated, chronically dislocated knee, walked in my office like this on crutches, just like this. And all those ligaments are damaged and stretched out. This is another good indication for a hinge, where all the ligaments are completely torn and damaged. And she's still back to work as a housemaid and at 5 years. Going on to rehab, remember this test question is on every other year. The amount of bending in your total knee after surgery is related to pre-op range of motion plus or minus 10 degrees. It doesn't matter how you sort it and what processes you use and how you balance it. The ultimate range of motion, study after study after study, has shown that your post-op range of motion is equal to your pre-op plus or minus 10 degrees, and that's the most important correlating factor. Going on to prosthetic joint infection, my favorite. What you need to understand here is the biofilm. You've got to determine whether it's acute or chronic infection, and that's based on the biofilm. Biofilm, also known previously as glycocalyx, what I'll say is biofilms on implants cause chronic disease, and understanding biofilm enlightens one to the logical treatment. All bacteria make biofilm. All foreign and devitalized tissues that come to biofilm if you're exposed to bacteria. So biofilm form on dead tissues, dead bone, and prostheses. Characteristically, it's made of 15% cells, 85% matrix. The matrix is polysaccharide. That's a test question. Biofilms have structure. They live in a microecology and actually communicate with lactone derivatives. But just remember that it is a polysaccharide coating. All bacteria make biofilm. You start off with planktonic cells, individual cells. They attach to the metal. They grow to a certain size. You get to a certain quorum, and then they send out molecules that form the biofilm. Once in the biofilm state, this polysaccharide coating allows them to grow and proliferate at a centimeter an hour in the perfect setting, and it can form over the implant very quickly in 4 to 8 days. Again, it's 85% matrix, which is polysaccharide. It has structures. They have mushroom clouds. They have streamers. These streamers will break off and go to adjacent areas of the prosthesis, or will go into the blood and seed other areas, other prosthesis, and other parts of your body. You've got to know that in prosthetic joint infection or osteomyelitis, in the biofilm state, the bacteria become 1,000 to 1,500 times more resistant to antibiotics. These bacteria express genes which change the cell wall structure or membrane structure, and they become much more resistant to antibiotics. And that's why you cannot treat chronic infections alone once you're in the biofilm state. They are resistant to antibiotics. The biofilm is permeable. And the antibiotics can go all the way through that biofilm, all the way down to the base of the prosthesis within 90 seconds. So it's not a shield. It's just that you've changed the structure of the bacteria. And they're resistant to white cell attack and phagocytosis. You nibble on one side, and then it'll just grow on the other side. And they're resistant to the antibodies. So in terms of prosthetic joint infection or osteomyelitis, biofilms can colonize and grow and cover surface within 4 to 8 days. Prolonged wound drainage should not be allowed because whatever can come out can go in. So bacteria go in, they get a biofilm, you have a chronic state. So with chronic infections, the only way to treat a chronic infection is you've got to planktonize the cells. Right now, at the present time, there is no detergent, no medicine that you can do to give to dissolve a biofilm. So the only way you're going to get rid of a chronic infection in a biofilm state is to take the parts out, take out the dead tissue, and take out the dead bone. And that's also known as a radical debridement. So in terms of prosthetic joint infection, what you want you divide them into early post-op infections, less than 4 weeks, hematologous infections where the knee has been in for 4 or 5 years, and the infection's been around less than 4 weeks, and then anything after that, greater than 4 weeks, is called chronic because you're in a biofilm state. So in terms of treatment, it's quite logical now. If you have early post-op infection, you open up the knee, you do an irrigation debridement with retention of components, you change the modular parts to get rid of that thin fibrin membrane layer, and resect the components if the IND fails. But the point here is you catch it early before the biofilm, you wash it out. You don't arthroscopically wash your knees, you open them up wide. Radical sonovectomies, radical debridements. Don't answer with arthroscopy. Same thing with hematologous infections. Again, the infection is acute, no biofilm yet. You do an IND with retention of the components. You change the modular parts. Again, if it fails, then you got to take the parts out and start over with a 2-stage procedure. If it's a chronic infection, biofilm state, dead bone comes out, dead tissue comes out, parts come out. The reason for failure after a chronic infection is retained cement or foreign body. So you've got to do a radical debridement. So the most common reason for recurrence is retained debris, either cement, metal, or dead bone. Okay? The options are 2-stage reimplantation, arthrodesis, permanent resection, or amputation. It depends. The deciding factors are the systemic health and the immune status and the local health. So if you're compromised, you may want to end up doing an amputation. If your local tissues are compromised, you might want to do a muscle flap. So it just really depends. Amputation versus reimplantation, they will guide you on the test question. This patient is 87 years old. This patient has no extensor mechanism. He has had 2 draining sinuses and 1 prior attempt at a salvage, and he has a recurrent infection. They're going to lead you down a path of amputation. And on the other hand, a 50-year-old gentleman who has a chronic infection, the parts are removed, he's healthy, his immune status is normal, his SED rate and CRP are normal, they're going to lead you down the path of reimplantation. But they will tell you whether you are healthy or not. And that's how they're going to guide you on those questions. Okay. The evaluation for infection, most people follow the SED rate, but the C-reactive protein is your best indicator. So you'll start seeing CRP on your test questions. A normal CRP indicates absence of infection most of the time. Remember that aspirations are only positive 50% of the time. The other way to help assess infections is bone scan and indium scans together. The two are pretty sensitive. In terms of evaluating for infection, frozen sections, the answer has been less than 5 white cells per high power field is considered the standard. If you're above 5 white cells per high power field, you have to worry about infection inside the joint. This is either at the time of revision surgery or at the time of reimplantation. Okay, so I'm going to go on to the next talk, which is my patellofemoral. I'm going to focus this theme on patella tracking and total knee. I'll give you some pearls on helping you with the boards. Again, patella management. Remember that the most common complications in total knee involve abnormal patella tracking. And that was a test question 1 or 2 years ago. This is going to focus on tips and pearls and concepts of avoiding maltracking. Basically, patella management is an exercise in Q angle management, which we talked about on the techniques in the last lecture. Remember, the Q angle is the angle between the line and pole of the quadriceps and the patella tendon, which was shown by Ficott and Hungerford. And I'm not going to go over that much because we just showed it yesterday. It's basically the line of the extension mechanism and line of the patella tendon. The significance is that increased Q angles give you increased subluxation forces. And just remember that in a total knee implants are less able to accommodate for these factors because you have round patella domes. The flanges are not the same as the native knee. They're not as constrained as the native knee. So increased Q angles increase the lateral subluxation forces, and in a total knee, they're more prone for lateral subluxation. So the goal in patella management in total knee is to minimize Q angles with techniques that do not compromise mechanical alignment. Remember, mechanical alignment is your #1 priority in your total knee, restoring mechanical alignment and balanced ligaments. And so you don't want to compromise mechanical alignment or the stability of the knee implant. So you don't want to cheat on those. So you want to avoid techniques that increase the Q angle, and you also want to avoid techniques that don't overstuff the patella height. Overstuffing causes tension on the lateral retinaculum and causes the increased lateral releases. One of the big rules, thou shalt not internally rotate the femoral component. They will ask this some way or the other on the question or on the test. Thou shalt not internally rotate the femoral component. The result is an increase in Q angle. The lateral torcular flange forces the patella medially. The net is a lateral tilt of the patella, and you have an unbalanced flexion gap. Here's the example here. You have internal rotation of the femoral component. The line on the femur is the epicondylar axis where you should be, and so you have relative internal rotation. The patella stays where it should be, but the net result is lateral tilting. You have a loose lateral compartment with instability, or the other way to think of it is a tight medial compartment with stiffness. And so what will happen is you have a stiff, painful total knee. You bend the knee, and you will see that relative to the epicondylar axis, you have internal rotation, and that's one of the more common reasons for revision surgery for mechanical malalignment. So what you really want when you're doing your total knee is slight external rotation of the femoral component. That gives you a rectangular flexion gap, gets you centric patella tracking, a balanced flexion gap, and gives you stability without stiffness. And you'll say, well, why do you want slight external rotation of your femoral component? The reason is if you look at the native knee and you look at the native tibia, the actual native tibia on average is sloped in the coronal plane about 3 degrees. We're in 87 degrees. And when we do our mechanical jigs, we're not good enough to cut 3 degrees all the time. So what we end up doing is cutting the tibia at 90 degrees. And then what we had to do, and that's the middle slide right there, just to show you, you're cutting the tibia at 90 degrees, and so that leaves you with a trapezoid gap. And what you've got to do is you've got to externally rotate that femoral cut to give you a flexion gap that's symmetrical. So basically what we end up doing is externally rotating the femoral component 3 degrees to 5 degrees. So here's an example, revision. This is a revision of total knee for stiffness and pain. The femoral component was massively internally rotated, and so what we've done is externally rotated the component and filled up that gap with cement. And we use revision components to augment it and re-rotate that component. So in terms of the methods to determine femoral rotation, there are several methods that you can use. You can use the AP axis of white sides. So you draw a line from the center of the trochlear groove to the intercolumnar notch, and you draw a line perpendicular to that, and that's where you set your external rotation. The other one is the epicolumnar axis. John Insall has shown that the epicolumnar axis, if you're parallel to that, is close to, most of the time, flexion gap or the epicondyle or the rotation of 3 to 5 degrees. The last method is posterior epicondylar, and that should not be epicondylar, that should be posterior condylar axis. So you put your sleds on the bottom, you externally rotate it 3 degrees on your jig. The last method is the tibial alignment axis. You just take your tibial jig and move it up. You've cut your tibia at 90 degrees. You just bring the jig up a little bit higher and draw your line, and that will give you your flexion gap. So those are the 4 methods to assess external rotation. Dick Scott has shown in a nice study that 90% of the time, the white side axis, the epicondylar axis, and the posterior condylar axis all line up. So I pick 2. I usually, when I do my total knees, I will do the white side axis and draw it out, and then I will do the posterior condylar axis and dial in 3 degrees. And then if there's any problems, I will use my epicondylar axis as a reference. Beware of lateral femoral condyle hypoplasia. If you have a lateral femoral condyle that's hypoplastic, if you use the posterior condyle as a reference, you're going to be off. You're going to have net internal rotation. So if you have a valgus deformity, the most common reason for valgus knees is lateral femoral condylar hypoplasia. And when you put your sled on and dial in external rotation, it's not going to be enough. That's the time that you use your epicondylar axis and you use your white side. And that's why 90% of the time they line up. 10% of the time they don't line up because you have some of these deformities. And those are the nuances of total joint management. So you've got to use other methods to determine your rotation. So remember, with lateral femoral condylar hypoplasia, you can't use the posterior sleds for your rotation. And that's where you've got to rely on your epicondylar axis. Next thing, thou shalt not internally rotate the tibial component. The tibial component generally should be centered over the medial third of the tibial tubercle. If you internally rotate the prosthesis such that it is medial to the tibial tubercle, the net effect is external rotation of the tibial tubercle. And if you have external rotation of the tibial tubercle, that increases your Q angle. So you should be centered over the junction of the medial and middle third of the tibial tubercle, gives you a normal Q angle. If you internally rotate the component, that net result is external rotation of the tibial tubercle, and that increases your Q angle, and that's where you get subluxing patellas. Everybody understand that? Okay. So thou shalt not internally rotate the femoral component. Thou shalt not internally rotate your tibial component. Valgus deformity should be corrected to a neutral mechanical alignment. All knee prosthesis designs now have sophisticated equipment that you should be able to correct your valgus all the way down to a neutral mechanical alignment, which is down towards 6 to 7 degrees. Otherwise, you're going to have an increased Q angle and you're going to have subluxation. When using a posterior stabilized implant, a little trick that you can use is you can consider lateralizing the femoral component because you don't have to center your component over the PCL, so you can put it medial or lateral. So if your component's a little bit smaller relative to the bone, you can shift it. And that gives you a net decrease in Q angle. That's a little trick that you can use. So femoral component just generally centered over the PCL with a cruciate retaining knee. However, with a posterior stabilized knee, you cut out the PCL, you can put that over to the lateral side if you want to. You don't want to overhang it, but as an example here, I overhung it just for demonstration purposes. You can lateralize that femoral component and decrease your Q angle. And if you had somebody with a valgus knee and you had to have a big correction, putting the femoral component on the lateral side is going to help your Q angle, and that's just a little trick to help you with your patella management. Another trick that I've seen on the test is patella component position. You can consider medializing the patella component. So instead of, like an example of resurfacing the entire dome, you just put it on the medial side. Then you don't have to pull that lateral retinaculum all the way over. So here's the typical scenario. If you have a medialized dome, this is where you put it. If you had a large dome, then your center is going to be way over here like this. And what's going to end up doing is that you're going to have to pull that patella over, and the only way you're going to have to pull that over is you're going to have to do that lateral release right here. So what that small medialized dome does, keeps your tension off so you don't have to pull that lateral retinaculum over. So that's a little trick to obviate the need for a lateral retinacular release. And as a general rule, lateral retinacular releases tend to be morbid. They cause a lot of swelling, they cause a lot of pain, and a lot of edema. So the technique requires a small patella component. You can only be used in minimally constrained flanges. You can't have a femoral component flange that's really high, because what will happen is that bone of the patella will knock on that high lateral flange and cause a little bit of pain in that area. The incidence of lateral releases is definitely less with patella buttons that are small, and this was shown by Ellis and Espinosa. So you can really cut down your rate of lateral retinacular releases with a medialized dome patella. Hugh Cameron's shown that with this medialized dome, the incidence of anterior knee pain is no different than if you resurface the entire area of the patella, and that tends to be shown in other studies as well. One other thing we can talk about is patella height. If you overstuff the patella and make it too tight, then you stretch out the lateral retinaculum, and that causes lateral tilt of the patella. The total patella height is managed by the patella bone thickness, so if you don't cut enough, it's going to be too thick. Components come in certain sizes. If you choose one that's too thick, then you're going to overstuff it. The trochlear bone on the lateral side, if you don't cut enough flush with the femoral shaft, then you're going to overstuff it. And also, if you have a femoral component that's pretty thick, then you're going to overstuff it. So what you basically want to do here in patella height is that you want to have a normal patella. You want to measure your patella beforehand. Say, for example, it measures 23 millimeters. You want to cut the bone off and replace it with a dome of the same height so you don't make it too thick. So you have a restored total thickness, you have a normal retinacular tension, and you don't have to have any lateral overpull, so you don't have to do a release. Overstuffing the patellofemoral joint causes this problem, just like you see right there, even though you've done good alignment of your femoral component and your tibial component. So what you want to do is you've got to make sure you cut your bone thin enough. You've got to have a design where your patella is not too thick. I mean, the component itself. You can't leave any leftover trochlear bone. You've got to cut it down flush, and you've got to choose a design that's not too thick for your patient. So there's those 4 issues that you've got to think about. This study showed here that there's a direct relation to overstuffing the patella height. So if you overstuff it, you're much more likely to have lateral releases. Okay? In terms of patella height management, you can also look at design here. This is a high lateral flange, and this is a narrow groove. This is a very broad flange, very forgiving. This is a recessed trochlear flange and a lateral flange relief. So there are nuances in your design to help you with your patellofemoral management. So not all implants are the same. Okay? So this is the area that's relieved out, and this is the area that's relieved out compared to the other side. Patella baja is another issue. Remember the insult to body ratio. Remember, it is patella tendon length over bone length. So when you measure, remember the ratio, it's tendon first over bone. And so if you have patella baja, the ratio is less than 1. So remember, insult ratio, tendon length over bone length, and then that makes the ratios make sense to you. It's patella baja is frequently seen after tibiotubercle transfers or slides where you have realignments for patellofemoral maltracking, proximal tibial osteotomies, and trauma and fracture. The treatment options are very few, but one way to take care of the baja is to lower the joint line with distal femoral augmentation and lower the tibial bone cut. This requires a revision knee system. So here's your total knee. The slide on the left is your original joint line, and what you want to do, your patella is really low. What you can do is you can keep the patella tendon in the same position. What you do is you cut more tibia, bring the joint line down to here, and you augment the femur. So obviously you've really screwed up your sagittal plane management, and what you're really doing is using constrained revision knee implants to take care of this difficult problem. So that's one way out of that, and they probably will not answer that because that's a very sophisticated question. But that's what you can do. The principle here is lowering the joint line to help with your patella baja. One other thing you can do is a small patella dome superiorly placed with a reduction patelloplasty. So I saw one test question, if you had relative baja and you had problems with maltracking, placing the component medial and superior is a good place to put your patella because that will help with your maltracking laterally, but it will also help with your baja. So you can trim that extra bone inferiorly. If you have a patella component that's still impinging, you can trim some of the patella bone itself or trim some of the polyethylene. Here's an example of patella baja. What happens is that this is where the patella needs to be way up here. Here's your baja. When you bend, you have impingement right there. And what you can do is, if your polyethylene's in the way, you can trim this polyethylene right here, and you can also trim this polyethylene here, or put a smaller dome, put it up superiorly, and then just trim this bone away right here so that when you bend your knee, these don't make contact in this area. Remember, if you're going to trim the polyethylene, you can't trim the articular surface. You're just going to trim that middle section between the two condyles. But the better answer is superiorly placed small dome. If you're going to place it superiorly, you're going to place it medial, superior medial, okay? One other option for extreme BAHA is you can cut the patella and not resurface it. That will lower the patella height so you can allow it to bend a little bit more. And for real extreme cases, you can do a patelectomy. But remember, if you do a patelectomy, then you got to use a posterior stabilized knee or a constrained knee, depending on your stability of your knee. You can't use a cruciate retaining knee when you take out the patella. Patella BAHA, you can raise the extension mechanism. That's with a tibial tubercle cephalad transfer. So you take the tibial tubercle, pop it off, and put it up. I will tell you that's risky because there's not a lot of bone left underneath that prosthesis, and there's a lot of problems with pull-off. That's been espoused by our white side, but for the boards, that is not a standard answer. I just want to let you know that is a potential option, but you shouldn't answer it in that regard. Think about the mild patella BAHA, superior small dome placed medial. Think about patelectomies for extreme cases. Okay. Patella clunk syndrome, you've got to know this one. It occurs in posterior stabilized knees only. That's going to be in there some way or another. Basically, the scar tissue in the superior patella that gets caught in the box in the knee as the knee moves in extension. It's noted. Patient is sitting down. They come out of the chair around 30 degrees of flexion. They feel a little catching and then a pop and a snap. That's patella clunk, and that's the description of the procedure or description of the problem. It's basically this scar tissue right here that forms and that gets caught in the box. So that as the knee comes into extension, that scar tissue gets caught in that posterior stabilized box and causes your snap. The treatment is arthroscopy and debridement of the nodule. Some people say a small arthrotomy is one of those others, but the answer is debridement. And they're not going to ask you arthrotomy versus arthroscopy. They're going to give you arthroscopy or some other open debridement. Insol has always said that if you're doing posterior stabilized knees, you should always take the synovium off the quadricep tendon right in this area so that when you're doing your primary knee, you should take all that synovium off there so you don't get this problem. This is what it looks like arthroscopically. I could see them giving you this picture right here on the boards, and you can see this fibrous nodule on top of the superior polar patella. It's this tissue that gets caught in this notch right here and gives you your clunk. This is the arthroscopic debridement, cleaning out that fibrous nodule. Memorize this picture right there. That is patella clunk syndrome. Patella tracking, remember that we assess patella tracking with no thumbs technique, that even though you do all of this balancing, 55% of the time you can get tracking. Sometimes it's tilted and sometimes it's displaced. This is the test question you need to know, is that post-op mal tracking is predicated on pre-op mal tracking. So if you had mal tracking pre-op, you're most likely to have mal tracking post-operatively. So if you started with a knee with normal patella tracking and you did a technically efficient job, your chance of mal tracking is low. If you had a total knee that had mal tracking preoperatively, you can correct it most of the time, but sometimes you're going to get mal tracking. It's those who have mal tracking pre-op that are going to have the problems with mal tracking post-op. And that's a test question. Okay? That was shown by Dave Bindleglass. Remember, though, that pain, flexion, and fixation tend to be unaffected by tilt and displacement. So post-operatively, if you see an x-ray with lateral tilt and lateral tracking, not all the time does that cause pain. And so if you see that on your x-rays, don't always assume that that's the source of your pain in your total knee. Because many times, I see a lot of mal tracking in my office, and they don't hurt as some people do, but most of the time they don't. Now, do you resurface the patella or not? This tends to be a very controversial issue. They tend not to ask this on the boards. I've seen it on in-training questions. If you're going to not resurface the patella, as a general rule, most surgeons resurface, but the indications for non-resurfacing are non-inflammatory disease, i.e. non-rheumatoid, their cartilage eaten up over time, tend to be lower activity level, no dysplasia or mal tracking, and no BAHA. Can't have any BAHA in this situation, okay? This is a one randomized prospective study. It is the VA study down out of Texas. They examined osteoarthritis patients only, no deformities over 15 degrees of varus or valgus. Postoperative anterior knee pain was about the same between the two groups, but look at this group. OA patients only, no deformities, no BAHA, okay? They found no difference in knee scores. It tended out to be obesity and the extent of achondroplasia didn't correlate with pain scores, and that both groups, or the non-resurfaced group, did have a resurfacing rate of 12%. So some people were later converted. So if you're going to go for the boards, for non-resurfacing, low activity level, no dysplasia, no BAHA, non-inflammatory disease. Okay? So remember that patella tracking is not always straightforward. It's an exercise in Q angle management. You want to minimize your Q angle. Do not internally rotate the femoral component. Do not internally rotate the tibial component. You want to correct excess of valgus down to a neutral mechanical alignment. Measure the overall patella height and don't overstuff. You want to, the little tricks that you can use, you can medialize the patella component if you want to. You can place superior placement of the patella for BAHA. You can lateralize the femoral component, but you can only use that in posterior stabilized knees. Okay, last lecture for the joints. I appreciate your patience with me. This last one is going to be what we call, the theme is catastrophic wear of total knee replacements. This was seen earlier in the last decade. Typical example, 58-year-old gentleman, 8 years from a primary total knee. Surgeon looks at the x-ray, he's done a bang-up job. 8 years later, this gentleman presents with a painless, warm knee. Painless effusion, warm knee. Not too terribly painful, relatively stable. What you see here radiographically is, here it is. You see some osteolysis, but the components are not particularly loose. But if you open up the knee, you look in there, wham, polyethylene is just destroyed. You take the femoral component off behind there, and you have massive osteolysis of the knee. It requires allograft reconstruction with femoral head allografts and a constrained prosthesis. Notice here, for patella tracking, I've medialized it with a small dome. I've left those pegs in there, but notice there, medialized patella dome for tracking. So in terms of the description of catastrophic wear, it is the premature failure of prosthetic implants due to excessive loading, macroscopic failure of polyethylene. This is not a microscopic wear problem like you see in the hips. It is a macroscopic failure, and we're going to talk about that. And then you have subsequent mechanical loosening. That is not a microparticulate debris problem like total hips. Total knee mechanism of polyethylene failure tends to be pitting and delamination. And remember that. Total hip wear is microparticulate wear debris. Knee wear is pitting, delamination, and I'll show you on these slides coming up. Osteolysis is a secondary phenomenon in the knee failures. Okay, it is a multifaceted problem. The areas of concern are polyethylene thickness, articular geometry, joint kinematics, polyethylene processing, and polyethylene machining. And these are the last 5 topics that are going to get you some pearls for the boards. In the prevention of catastrophic wear, plastic thickness is critically important. Wright and Bartel have shown that you've got to keep the stresses, or you got to keep the polyethylene of a certain thickness. Otherwise, you're going to have high stresses to the polyethylene. To keep the contact stresses below the yield strength of ultra high molecular weight polyethylene, you've got to be at least 8 to 10 millimeters. On the boards, if you see this, answer 8 to 10. If you have the answer 4, 6, 8, 10, and 12, answer 8. If it's a choice of 6 to 8 and 8 to 10, you choose the 8 to 10. If it's a board answer and it just gives you one number, choose 8. Okay. Below that, though, it gets too thin. The polyethylene's too thin. You get stress concentrations, and the polyethylene will fail. So as an example, on the earlier knee designs, these are just like 8. This was shown by Chillig out of USC in Columbia, South Carolina. He took all these implants, cut them right down the middle, and then with the metal and plastic being 8 millimeters, he said, hey, this AGC knee is 8 millimeters. Well, if you cut the metal and the plastic down the middle and measure the bottom of the dish, the polyethylene is only 4.2 centimeters thick. So a lot of these earlier designs had thicknesses that are well below the 8 millimeters. So that was one big problem with the earlier knee designs. People were what we call bone conserving, to make thin tibial bone cuts. We want to preserve it for revision. And that was a pretty bad thing because these polyethylene thicknesses were too thin. So you want to keep these polyethylene thicknesses at the base of their dishes at least 8 millimeters. The other issue in terms of prevention of catastrophic wear and total knees, you want to avoid flat polyethylene designs. Remember, I was talking about before about total knee designs, that the initial cruciate retaining knee designs were flat, so you could get some rollback. what that happened was that these flat femoral designs had low contact areas and high contact loads to the tibia, and that caused the plastics to deform and crack and delaminate. So flat polys in the earlier designs were bad because it caused a lot of catastrophic wear. So this is what we're talking about. Flat designs had low contact areas, which you've seen in those lines in blue, and you had high contact loads. So in terms of the articulation design and total knees, board question, in-training question every couple of years, you want to minimize contact loads and maximize contact areas. Basic engineer design. You want to spread out those forces evenly throughout that tibial component, and you want to minimize those loads as much as you can. And if you load it too much and you edge load it, for example, you're going to dent in that polyethylene and cause damage. So in terms of the articulation design and total knees, there's been a shift more towards the congruent articulation profiles. So instead of the on the X-ray on the left where you have a flat design there, you have the more congruent, more round designs, which give you higher contact areas and lower contact loads. So that's what that looks like interoperatively, rather than those old flatter designs. Okay. So in terms of the prevention of catastrophic wear, we also learned that you want to avoid excessive rollback in your knee. Remember, I told you before that the first generation designs saved the PCL, got the rollback so you got better knee flexion. But the second and third generation designs had problems with catastrophic wear. So the initial designs incorporated this femoral rollback, which we were talking about, which is the posterior shift of the femoral tibial contact point as the knee bends into flexion. And that was good. We wanted knee flexion because that's what the patients wanted. At first, Blunt and Walker showed that femoral rollback was thought to be good. If you preserve the PCL, you took out the cruciate, anterior cruciate, but saved the PCL, you still could get increased knee flexion, and that was thought to be better knee kinematics. And Blunt and Walker showed that in a lab study that when you had sliding wear, you had severe surface and subsurface cracking with high wear. If you had rollback, i.e. rolling, you had a shiny wear track with minimal cracking and wear. And people thought that if you saved the PCL, you would have this nice, normal, fluid rollback in the knee, and you would have this rolling motion, and it would give you this shiny wear track and good wear. But fluoroscopic exams showed that there was a paradoxical roll forward and backward sliding with PCL retained implants. What people didn't realize is that to have that normal rollback in the knee, you had to have an ACL and PCL together to have that work. Now, you still get rollback with a PCL retained without your ACL, but it slides back and forth. And if you look at the fluoroscopic studies, the knee bends up a little bit and then slides forward. It bends and rolls back a little bit and slides back. And so you have this paradoxical sliding motion. And so that if you look at the fluoroscopic studies, it's very kinematically displeasing. There's more sliding than there is rolling. And that's one of the reasons for this catastrophic wear. And you'll say, well, why does this happen? As I talked about, it's the loss of that linked ACL, PCL kinematics. You lose that 4-bar construct. The joint, and also the joint line is not exactly reestablished in many cases. So this is the 4-bar link concept. The ACL and PCL are each linked by 2 bars to the femur and on the tibia, and that there is an obligatory rollback when those two are together. So it gives you a nice rolling motion. There's a ratio of 4 to 3 in the beginning, and then the ratio changes in end flexion. But the point being is that the ACL and PCL have to be linked together to get that rollback. Also, you have to restore the instantaneous center of rotation, which is controlled by all 4 ligaments. So if your joint line is raised by 1 or 2 millimeters, those collateral ligaments are not going to be centered through the cruciate ligaments, and you're not going to have that same rollback phenomenon that you have in the normal native knee. And finally, you take out the ACL, all bets are off. So you're not going to be able to get that normal rollback. So in summary, in cruciate retaining knees, when you take out the ACL and you change your joint line maybe 1 or 2 millimeters, you have very kinematically displacing motion. It is a paradoxical sliding motion and rolling. The majority of the motion is sliding and not rolling. And the sliding wear is bad for polyethylene, which we talked about in that earlier study. So that's one other factor about this catastrophic wear. And we still have that problem. And perhaps maybe what we need to do is do these total knees and have Mark Miller come in and do these ACL reconstructions so we can get better motion. Right, Mark? Yeah, that's right. That'll never happen. So in summary, in terms of regarding wear. The other issues that we're going to talk about is polyethylene processing. Remember that polyethylene manufacturing and post-process sterilization are important in your polyethylene. Remember, we had that whole big lecture yesterday about that. So what you want to do is some of these early knee designs had ram bar extruded polyethylene, and there's a lot of variation in the polyethylene quality and depending on the region within the bar. They also had calcium stearate additives in these early knee designs, and those had fusion defects within the polyethylene. So in these early designs, you had flat on flat, you had ram bar poly, you had calcium stearate in the system. The polyethylene thicknesses were 4 to 4.2 millimeters or 5 millimeters. You're throwing all of these into the equation to get this catastrophic wear. Remember that in terms of polyethylene manufacturing, better wear is consistently achieved with direct compression molding process. Remember that direct compression molding gives you your best polyethylene for wear. The worst is ram bar extrusion added with calcium stearate. Those are really bad polyethylenes. And the last key point is polyethylene sterilization. Irradiation of polyethylene stored in air packages is bad because remember we were talking about the oxidation of polyethylene. You oxidize these polyethylene, or you radiate these polyethylene components, store them in air, you get chain scission, and you get oxidation. One other thing that I didn't talk about in the other lectures is polyethylene machining. The machining process is thought to put microscopic strains on these polyethylene chains. It literally stretches out these polyethylene chains and places the amorphous areas on stretch. Remember, you had the crystalline areas and the amorphous areas. So if you machine them, you stretch out those amorphous areas, and they're more susceptible to oxidation. So if you look at polyethylene machining, you have the crystalline regions, which are those areas right there. Remember, I popped out the green laser. Remember green laser style points, okay? And what you have here is the amorphous areas are right here. So if you take that polyethylene, get a ram bar extruded product, and then you machine it with a cutting tool, that machine literally pulls those chains apart. And then you irradiate it, you're going to cut those amorphous areas right where the strain area is, and that's where you're going to get those areas that are going to be cut. And as it turns out in the machining process, the area of polyethylene stretch tends to be most pronounced 1 to 2 millimeters below the bearing surface. So the test questions have been that white line 1 to 2 millimeters below the tibial polyethylene, that's the area of oxidation. Why did it oxidize? Well, it turns out the formula is that you take this polyethylene and you machine it and you stretch out those amorphous areas and then you irradiate it in air. That's the highest area of oxidation right there. And that's what gives you, that's what gives you that white line of oxidation. And that's that classic white band of oxidation below the subsurface. And I could see a test question where they're going to show you a cutaway of polyethylene, and they're going to show you this white band. This white band is caused because of A, B, C, or D. And what it is, it's going to be oxidized polyethylene. Okay? So in terms of the machining process, the resultant wear patterns in total knee typically have been, and this is a board question, subsurface delamination, fatigue, cracking, and pitting. And why is it subsurface delamination? It is because you've irradiated that stretched out area that's been machined. Make sense now? And so you end up, if you don't delaminate the entire surface, then you're going to get pitting and cracks. So the wear pattern in total hips is microscopic wear. In total knees, it's subsurface delamination or cracking and pitting. So in terms of the catastrophic wear process in total knees, the scenario, you start out with a metal back tibia with a thin polyethylene insert. You have a flat articular geometry, medial to lateral, which is seen on the x-ray on the left. The next thing is you have low contact areas with high contact loads, which is seen with those x-rays right there. You throw in the scenario of saving your PCL where you have that paradoxical kinematics of sliding back and forth. You throw in machined ram polyethylene irradiated in air where you get that subsurface delamination from your oxidation, and then you get that poof, that catastrophic wear. So it's all of that thrown together. And with all that, there's a million questions that they could ask you. So if you understand that lecture, that's going to get you through all those little tiny test questions. So in terms of total knee designs, for you guys, practically what you want for the future is you want a reduction of the contact stresses. You want to actually reduce the rollback because you're not going to recreate it normally because we don't recreate the forebar. You want better polyethylene processing, and you want reproducible flexion. We're tending to go towards the congruent articulation profiles to maximize the contact areas. We're going to get flexion via posterior slope and or posterior center of rotation. So instead of putting the tibia center of rotation in the middle, we're going to put the rotation back on the tibia so you don't have to worry about the rollback. You're going to use direct compression molded polyethylene. Most of our companies now are all going to direct compression molding process. You're going to irradiate the implants in an oxygen-free environment, which is argon or nitrogen packaging or vacuum packaging. John Insall has talked about getting rid of the PCL altogether using a posterior stabilized knee, which he truly believed was the way to go, or what we call a posterior cruciate accepting knee, meaning you save the PCL, but you're not using the PCL for rollback. You're just using it as a static stabilizer so it won't sublux. And so what you're doing with the PCL is it stays there and you put a congruent articulation. You're just putting a posterior center of rotation with the implant. So if you look at it, we started with a total columnar knee in 1973. ACL, PCL is out. You save the PCL to give you a little bit more flexion, and which was thought to be good. Patients were happy. You flattened out the polyethylene. You got the rollback, and then you got this catastrophic wear. Then he said, oh, crap, I got this polyethylene wear. We've got to do something about it. So you minimize the rollback. You change the design back towards an congruent articulation. You go back to a PS or PCL accepting knee where you take out the PCL altogether. And so you started in 1973, and now you got an implant right now in the year 2000. See the difference? Not much. So we've come full circle in about 30 years. So that's where we are in total joints, okay? So I thank you very much for your time.